Cost today is a big issue, as it should be. A lot of these biologics are extremely expensive, and they add significant cost to chemotherapy and to the care of patients. And this is not just particular to bevacizumab and cetuximab, but to most biologics. And the problem is two-pronged. One is a problem of cost. In the long run, two is a problem of access. In the United States, may not be as much of a problem, but worldwide, it could be a problem. So let's focus on here and what cost means. In terms of when you think about adding a biologic to chemotherapy, you have to be able to justify whether there is enough benefit to justify the cost. And bevacizumab seems to be borderline when different models look at the cost plus chemotherapy. You get so the issue of cost of all these biologics is central now to how we think about utilizing them in the treatment of colorectal cancer. Resources are limited. Cost is becoming an issue when we look at the total health care. These biologics are expensive and add significantly to the cost of caring for these patients. So the question is always, is there a good way for us to measure how much benefit is worth it? How much benefit is worth it for us to add the cost of these biologics? There are different models that have been looking at the cost analysis, from a very simple to the more complicated models. Unfortunately, all these models have their complexities and their issues. They're also mostly retrospective rather than prospective, which makes them very difficult to interpret and understand. What's clear is we know they're costly, but we also know that they do benefit patients. And typically, most of the costs are measured around the median. Now, most patients are not at that median. Some don't benefit at all, and others benefit tremendously. And then if you look at the end, the tail of the curve, some patients live 7 or 10 years and even longer. So the question is, can you really look at the cost just based on that median improvement, and how can you improve the cost-benefit ratio? So one way to do it, and it really doesn't exist today, when you look at bevacizumab, we don't have a biomarker. We don't know who are those patients who benefit the most on this side of the curve and who don't. So it's very difficult to make sense out of this, and it's very difficult to make sense out of cost. With EGFR inhibitors, we know that half of the patients, those that have mutation, don't benefit from the drug. It's a very simple equation. Those patients do not receive the drug, and you saved half of these patients the cost of the drug. We need more positive predictors, meaning predictors that would tell us who would benefit, not just who wouldn't benefit, to continue improving the likelihood of these agents becoming cost-effective. But right now, despite all the analysis that we see and we hear about, it's very difficult to make sense out of these analyses. CLGB 80405 had a cost analysis integrated into it. It was relatively rudimentary, but it gave us a good reflection of what cost may look like in a patient receiving either chemo plus cetuximab or chemo plus bevacizumab. And it did seem that chemo plus cetuximab was more expensive than chemo plus bevacizumab, and at least from the authors of the study, the recommendation was that chemotherapy plus bevacizumab may be less costly and should be the preferred first-line regimen versus the cetuximab, given that there is not much difference in terms of survival. But I think overall, we have to be cognizant of the fact that although cost is very important, we are still at the baby stage in trying to figure out what models we should use prospectively to be able to understand a little bit more what life is worth.